Welcome to the Surveillance Strategies for Success, Part 4 conference call. My name is Hilda, and I will be your operator for today. At this time, all participants are in a listen-only mode. Please note that this conference is being recorded. And now I would like to turn the call over to your host, Ms. Deb Smith.
Good afternoon, everyone, and welcome to this Part 4 of the webinar series, Surveillance Strategies for Success. As Hilda said, my name is Deb Smith, and I'm an improvement consultant working with VHQC. Also on today's call, we have Carol Whalen, another improvement consultant working with VHQC, Karen McGoldrich, IP for Centera Lee in Virginia, and Sarah Lineberger, epidemiologist for Virginia Department of Health. So today we're going to be continuing the review of the 2016 NHSN annual training. The focus today will be on SSI and lab ID surveillance, and we'll be reporting the highlights from that training. I'd like everybody to know that this call is being recorded, and it will be on the VHQC online community within a week after the call, so you'll be able to use it as a reference at that point. So without any further ado, we're going to start this off, and I'm going to introduce Karen McGoldrich, who will be taking care of the highlights for the SSI training. So Karen, the floor is yours.
Okay, my presentation today will be on parts of what we, just a small part of what we learned on SSIs. It was quite a long training, and I do want to recommend that whenever NHSN does publish, if you weren't able to watch the live streaming event, when they do post the presentations, it would be really helpful for you to watch and look through it. I learned quite a bit, and it was just a lot to try to cram into today. Okay. Yeah, you can go to the next slide. Okay. SSIs, why does it matter and what's so important about it? You can see the statistics that are listed here about the number of infections and the number of deaths. I think one of the most important parts of it is the 11% of all deaths in intensive care units are associated with SSIs. So we know why it's so important to try to prevent these infections. And you can also see the cost affected, and that's important, obviously, to our hospitals and everything, too. But it actually adds to the extra length of stay of patients, and it is actually the 20% of unplanned readmissions after surgery is most likely due to SSIs. So how do you do your surveillance? How do you watch for SSIs? So the important part is to remember there's a lot of things you can do for your patients that are active, at least still in your facility. You can look and see decide which patients and which surgery types you're going to be monitoring. Then you want to look for signs of infections of some of your patients. Read through your admissions, your readmissions, your ED notes, your OR logs. Most of us get microbiology labs from our reports. Then you can review those and look for any infection that might be detected somewhere like that. Looking at your nurse's notes and physician notes, but even more important, go to your surgical units and talk to your staff and watch for things. A lot of times you hear about things that a nurse or someone will alert you about that you might not have known otherwise. You can also follow patients after they leave, and one of the most important ones is to do your post-discharge surveillance. It doesn't really matter how you do it. In my facility, we fax surgeries each month that we get to the surgeon, and they send back a letter saying if it's an SSI, and if so, what date, and what was it, a superficial, a deep, or an organ space. But you can do this by mail, by phone, or any other way. Also, you want to follow up with all your readmissions and your ED people. And also, you can also find what you can get from your coders. That's another way that we've been utilizing is anybody that's been coded for an SSI, it's easy to help you track those patients. And so how are you going to decide what you're going to track and what you're going to follow? So your roadmap is your plan. So it's really important to decide which procedures are most important. Most all facilities are using those that are mandatory reporting, and then any others that they may want to have tracking so that they can maybe eventually look at the SIR and try to figure out where they need to focus more. But remember that whichever one you track, it's very important that you follow the definitions and that you report superficial, deep, or organ space. These are the forms that are on the NHSN site. Once the denominator data, and it's important that all the form is completely filled out, because every one of those pieces that it asks you information about, you will have to enter. Then you have your SSI data collection form. Now, a lot of facilities, mine is one of those, that we have an automatic database that is pulled and then fixed so that it can be uploaded with the procedures. But I know not everyone does that. So whichever way, just make sure that anything you're putting in, you have all the answers to all the questions they're going to ask, or it won't take it till you're able to fill that in. So how are you identifying your HAIs? It's a little different for surgical site. We talked last time about CAUTIs and CLABSIs, and there's a lot of different things like infection windows and whether it's POA and different things. You don't have that with SSIs. So you have your date of event, and you can also have a secondary bloodstream infection, and you will still do your pathogen assignment. So you will still have those parts that are part of this. So your bloodstream infection can be identified, but it's a little bit different in this case. So you want to remember it's not your repeat infection window, and it's not your 7-day like you have with your other CLABSIs. This one is you can have up to 3 days before your date of event, your surgical site date of event, and you can also up to 13 days after your surgical site event. Any time during that time you have a matching organism, you can identify this as a secondary SSI. Secondary bloodstream infection, sorry. All right, and with these 13 days can actually fall outside of your surveillance period. You know that depending on your procedure, it's either 30 days or it's 90 days. So if you had an example here is you had one that was on day 29 and day 30, and that was your date of event. But you actually have 13 days past that day 29 that if you identify a bloodstream infection during that time, you can count that as secondary. Your date of event, just kind of reviewing our definitions and so everybody understands. So a date of event is the date that the first time, the first element is identified for the first time during the surveillance period. And remember your date of event makes a difference if your SSI becomes a different category. So if you have, the example we have on here is a date of event for a superficial for this patient was on day 6. But on day 25, they were identified as having an organ space SSI. So remember that you're only going to have one SSI for your event, or for your surgical procedure. So you want to remember you would go with the one that is the deeper level. So you would just report the second one. The pathogen assignment, just remember to go to Chapter 2 and identifying HAIs, and remember to follow your criteria there. The most important part on this slide is to remember that there are certain organisms that now have been excluded from NHSN definitions as being an HAI. So these that are listed here would be ones that they consider community infections, and it would rarely have caused any type of healthcare-associated infection. So remember, when you're doing your denominator reporting, even if you don't have a primary closure, you still report that procedure, and so it goes into your denominator data. And then an example here are some pictures of different types of closure, primary closure and other. So when you're putting it in, you either say primary closure or you say OTH for other. But you do have to indicate all of them. It doesn't matter even if they didn't completely close, it still has to be counted in your denominator. Another new thing they've added this year is infection present at time of surgery. So if there is evidence of an infection at the time of the surgery, in other words, it was preoperative, then you want to be able to note that. You're only going to be able to note that on your SSI event form. It doesn't ask you this question on the procedural. You can't really indicate it there. But if there's evidence of an abscess, it must be documented in the intraoperative note. It's got to be there. It can't be somebody going back later and saying that, oh, yeah, there was some infection there. And this, again, if it asks you that, when it's asked, was it present, you can say yes if it was there. Now, for instance, if they said they had an abscess and an organ space abscess and it was indicated, but later on your patient comes back with a superficial or deep incisional, you would have to say no because that infection wasn't in the superficial area, it was deeper. So you would have to say no to that. But remember just to indicate which it is. Okay, this is an example. Patient had an acute abdomen or they had an API performed and it had a ruptured appendix and it was documented that there was an abscess that had already been formed in the operative notes. 2 weeks later, the patient comes back and is diagnosed and meets the criteria for organ space intra-abdominal abscess SSI. So, does this patient meet the criteria for PANCOS? And it would be yes. And does that mean that we don't have to report this SSI to NHSN? And that would be nice, but no, that's not the case, and that's false. So all of them have to be reported. You just have to indicate which it is. You want to also remember in your denominator reporting, if you do 2 surgeries through the same incision, each of those surgeries get reported in the denominator if both of them are ones that you're tracking. So if you had CABG and you also had a cardiology mitral valve replacement, they went through 1 incision, the total time was 5 hours, and you would put 5 hours for your length of your surgery for each of those procedures. Remember about the wound class. It's very important to remember that these that are listed here, the epispillies, the gallbladder, the colon, the rectal, the small bowel, and the vaginal hysterectomies can never be entered as a clean. It's not even a choice on the drop-down box. So you have to remember at your lowest level you would have it to be clean contaminated. But for your hysterectomies, abdominal hysterectomies, and C-sections and others, you can actually indicate clean if that is the finding. Remember, your surgical team needs to be the one making these assessments. And also, if you were reporting hips and knees for joint replacements, I believe in Maryland they are required. They're not required at this time in Virginia. But if you have that in your plan and you're reporting them, you need to report which the procedure type. It's going to ask you that, so make sure you know that. All right, let's get into the different types. We know what a superficial, and remember we have 2 types. You have a superficial in the primary incision, and then you have a superficial in a secondary incision. An example here is a chest incision for doing the CABG. If they have a donor site for the blood vessel, that's your secondary incision. So when you report them, you have to say if it's primary or secondary. And these are our definitions of our our superficial SSIs, either primary or secondary. It has to be within 30 days, and it goes through the different criteria. Please remember that you have to meet all of these, or if it says at least one, that you meet one. And part of it's on this page, and go ahead and put it on the next slide too, Sarah. And you can continue to see that's part of the same definition. And you have to have all these things. So I'm not going to read through all the definition now just for time, but just remember that you have to meet one of those criteria. But remember also with superficials, the last one is D, and one of them is diagnosis of a superficial incision by a surgeon or attending physician. Okay, next. When you're reporting cellulitis, just cellulitis, redness, warmth, swelling is not a criteria for SSI. It has to be draining or something else if they have to, it meets one of the other criteria. But if it's a draining or they have a culture positive, that's not a cellulitis. So remember that because sometimes it is hard to make clear from the physician's notes. A stitch abscess alone is not necessarily an SSI. So you want to remember all these. But remember that a trocar site is considered the incision site for the abdominal hysterectomies, and that would be one you would consider. If more than one operation is done through the single incision, just like we had before with we're counting at the same procedure, we would go to the highest risk surgery would be the one. So in this case, if a person had a CABG and a cardiology procedure done, and then it developed an infective valve, then the SSI would be related to the cardiology and not to the CABG that was done. Okay, in our deep incisional, we have deep incisional primary, and again, deep incisional secondary, again, to the secondary site, just like we mentioned before. And with your deep incisional, again, your criteria is a little bit stricter this time, but you need to be either 30 or 90 days. It involves the soft tissues of the incision, so it's a little bit deeper, hence the name. So you want to look for notes that refer to the fascial muscle layers. And then you want to meet all the rest of these definitions down here also. Remember, if they culture it and the culture is negative, then that does not count. That's one of the criteria you won't be able to use. So it's real important to make sure it actually meets the definition. Okay, organ space. It has to be, again, within your 30 or your 90 days, and you want to remember that it's something deeper than the muscle layer, the fascial layer. And again, you've got your definitions that you've got to meet. So we're going to either obtain fluid, we're going to be doing it from CT scans, or you can go to the next page. Got some on that one too. And you've got any kind of abscess that's been documented through any kind of test or imaging test, and it's got to meet the criteria for an organ space definition where you have your definitions listed in Chapter 13. So you've got to remember it still has to meet that definition also. So, like I just said, and repeating one more time, I'm sorry, that it is important that it meets SSI definition, but it also has to meet the organ space definition. And this is just a sample of when you're pulling them up, when you enter them in NHSN. I'm sure all of you recognize this. You've got to make sure it matches. If you only have certain things, it may tell you you haven't met the criteria for this type of infection. So you want to make sure and put all that apply. And you also want to remember that certain procedures only can have certain criteria and only can organ space for them. So be sure and check Chapter 17, look at your list, and see which types of procedures would be able to fit this. And again, also another good resource from NHSN is it lists every type of procedure that could every type of infection that could be related to that procedure. So if it's not something that it can't be related with that, then it's not going to let you enter that. And there's your list that you can verify it with. Okay, another one that's kind of important is the intra-abdominal abscess. They've gotten a little stricter with it, and I'll give you some example later on here of one that wouldn't fit, but you might think it would. So it is important that you clarify if it's strictly in that intra-abdominal space, and it's not specifically in another organ or the liver, gallbladder, and some of the other places, so that it fits that criteria. And one thing to remember with this, the patient's still got to meet the definitions. They've still got to have all these other, like I said, the definitions that are on there. And then the most important part is, remember that all these organisms that I mentioned earlier, now we have the different ones, that these are the ones that can fit for abdominal abscess. Certain ones can't be identified with that. So if you're matching from the blood, you've got to have one of these in your bloodstream. In fact, for your bloodstream culture, you can't just say, oh, there's an organism here that proves that it was an intra-abdominal abscess. So you want to make sure you follow the right guidance on that. And again, these are the definitions that you've got to make sure you follow. And if it's an intra-abdominal abscess, whether it was related to the surgery or not, you just have to make sure you meet that definition along with your SSI. Okay, we have an example. This is a patient that had an abdominal hysterectomy. They came back on the second day of February. They had a temperature that would be high enough to be classified as a temperature would be one of your definitions. The CT scan reveals an abdominal abscess fluid in the deep pelvic area. The surgeon opened the wound, drained the dark fluid out. They sent it to the culture. They said an infected hematoma. The incision was closed. The culture comes back positive for Pseudomonas. Now, would you be reporting this as an intra-abdominal SSI? Would you report it as which is other reproductive organ areas, or would you report the vaginal cuff area? And the answer is the EP. So it's the other reproductive organ area. And a lot of people would miss this and think it should be intra-abdominal. Go to the next slide. Yeah, you can advance it. Sorry. So the reason why it's not is because it wasn't in the intra-abdominal area that it mentioned, but it specifically said it was in the deep pelvic area. So you got to make sure when you enter it, you know which area that truly it does fit the criteria for. For the ones that are reporting the hips and the knees joint replacements, there's really strict criteria to say if it is a true hip and knee joint infection. So make sure and follow this criteria, and this is for the periprosthetic joint infections. I have a different set of definitions for just a regular joint infection. So be sure you've got your definitions and know for sure that you're meeting that definition when you call that an SSI for that. So one thing that's really important is using the SIR. I think we've had other trainings and everything on that, so I didn't really go into that much. It's just the things to remember that's what's being counted in your SSR. So if you've got more than one risk factor missing, they tend to exclude that out of there. And they also have, if your duration is very short or 5 times higher than the 75th percentile, then it's not counted. The wound class isn't reported in that, and closures other than primary, like we mentioned, those others that we talked about earlier, they will not be running for your SIR. So when you pull that, those will be excluded. And for your colon, the risk factors that they look at are age, anesthesia, ASA, duration, whether it's done endoscopically, the medical school affiliation of your hospital bed size, and wound class. For the hysterectomy, they really only look at the age, anesthesia, the ASA, duration, and whether it was done endoscopically or not, and the hospital bed size. So remember in your in-plan, when you go to run your model, that when you pull the data, and this is the same data that goes to CMS, they only are going to count your SSIs that were deep incisional organ space. So if you run your SIR and it says you had 4 surgical site infections and you thought you had 6, it's probably because the other 2 were superficial. So just remember that when you're doing your comparison. And that's really all the end of my slides. At the very end of our presentation, there's some supplemental slides that are listed for SSIs, and it was a lot of different sites on the NHSN site that are good locations for references for you to follow up on things that you have questions about. And now I'm going to introduce. Okay, and I'm going to introduce Sarah. So from Department of Health in Virginia, and she is going to be reporting about Lab ID.
Hey, just one thing, Karen, before we move on to Sarah, we do have a question that came in to the participants, and it's a fairly common question that we get, but we want to make sure that we answer it clearly. So if a patient has a SSI colon PATOS, does that count against us for CMS?
No, they will pull that when you run your SIR and what is pulled for CMS. If that is clearly documented, then that one will not count. But that's why it's important to still go ahead and report it, but CMS won't count it.
Okay, thank you, Karen. If you have more questions, feel free to type them in the chat box, and we will get to them at the end. And if you haven't yet completed the polling question, please do so. It doesn't directly relate to today's presentation, but just something we're interested in terms of CAE surveillance.
So because of time limitations, we're mostly going to focus on lab ID event reporting for Clostridium difficile infection, or CDI. But most of what we will talk about also applies to lab ID reporting for MRSA bacteremia events, and there are additional lab ID slides at the end of your slide set. A reminder that the lab ID module has a different purpose than the device-associated module, and there is little thought process needed to report lab ID events. Lab ID events do not have infection window periods or RRTs or secondary BSI attribution periods, and the transfer rule does not apply to lab ID reporting, which we will touch on in the next slide. Lab ID events do have a date of event, which is simply the date of collection. Lab ID event reporting allows lab testing data to be used without clinical evaluation of a patient, making the data easier and less labor-intensive to collect. Lab ID events provide proxy infection measures of healthcare acquisition, exposure burden, and infection burden based primarily on laboratory and limited admission data. Lab ID reporting allows us to identify vulnerable patient populations and to assess the need for and effectiveness of interventions. Lab ID events are categorized based on date of admission and date of collection, with the date of admission being hospital day 1. Lab ID events are attributable to the location where the patient was assigned when the specimen was collected, which means that the transfer rule doesn't apply. A couple notes about reporting locations. As you all know, CDI and MRSA bacteremia lab ID events are required to be reported to CMS at the FACT-wide N level. I want to remind you that the FACT-wide N reporting requirement includes a requirement to separately report lab ID events from all emergency departments and 24-hour observation locations. Reporting from those outpatient locations allows NHSN to categorize events as community onset. Your facility should also report lab ID events from any other affiliated outpatient location for the inpatient admitting location if a specimen is collected on the same calendar day as the inpatient admission. Again, reporting from outpatient locations ensures accurate categorization of lab ID events coming into your facility. One more note about locations, and that is that your facility should also report lab ID events from all inpatient locations in the facility, including those locations with a different CMS CCN, which includes locations such as inpatient rehab or inpatient psych facilities. And again, reporting from these locations ensures accurate categorization of lab ID events. An incident CDI event is a specimen obtained more than 8 weeks after the most recent CDI event or the first documented for the patient. CDI is considered recurrent or a continuation of the same infection if a positive specimen is obtained less than or equal to 8 weeks, but no more than 2 weeks after the most recent CDI event for that patient. Recurrent cases are not included in calculations of SIR. If you have a duplicate event that is within 14 days, you would not enter it into NHSN if it is for the same patient and location. If the patient has moved, you are instructed to enter duplicate events into NHSN, but they will not be counted as recurrent cases. We would also like to remind everyone that your facility should be keeping an internal line listing or log of all positive CDI tests so that you can track duplicate CDI positive results. As you know, a duplicate CDI test and positive lab result from the same patient and location within 14 days should not be entered into NHSN. There is a lab ID event calculator available on the NHSN website to help with data entry decision-making around the 14-day rule. There is an example line list on slide 93 that shows you why keeping an internal line list is so important. A third positive for the same patient and location would be a duplicate event if it is within 14 days of the second positive result. But NHSN would still let you save it if it has been more than 14 days since the first procedure for that patient and location, because NHSN wouldn't have had a record of the second event that you didn't enter. Thus, your facility would be overcounting Lab ID events by inputting duplicates into NHSN. I want to talk briefly about Lab ID denominators because we get questions about them and have also found data entry discrepancies when doing quality assurance checks. MDRO and CDI patient days and admissions are not counts of events or number of patients with infection. They are your denominator data. And those definitions are on your slide. We'll look at a screenshot of the summary data entry form on the next slide. After 2014, CDI Lab ID SIRs also require that you enter CDI test type on a quarterly basis. And so that's reported on the summary record at the end of each quarter. That is in March, June, September, and December. If other is selected for CDI test type when a more appropriate test method is available on the form, your facility's data will not be risk adjusted to the most appropriate level. CDC would like to remind us that other should not be used to name specific laboratories, reference laboratories, or the brand names of CDI tests. Most methods should be categorized accurately by selecting from the drop-down options provided. Here is the Lab ID denominator form. After you've completed steps 1, 2, and 3 at the top to indicate fact-wide in and month and year, you will need to fill in 3 tiers or rows of summary data. For Tier 1, input total patient days and total patient admissions per the definitions on the previous slide. For Tier 2, take your numbers from Tier 1 and subtract locations with different CCNs, such as inpatient rehab facilities and inpatient psych facilities. If you don't have any of those units with a different CCN, then your numbers for Tier 2 would be the same as Tier 1. For Tier 3, take the numbers from Tier 2 and subtract any baby locations, which includes NICUs, well baby nurseries, babies in labor and delivery units, etc. And for a full list of baby exclusions, see the protocol. If you don't have any baby locations, your numbers for Tier 2 would be the same as your numbers for Tier 3 would be the same as Tier 2. Note that the numbers you enter for Tiers 2 and 3 shouldn't be 0, which is sometimes what we see when we do quality assurance checks, unless your whole facility is an inpatient rehab facility, which I don't think we have any of those on the line. And so NHSN doesn't give you an error for that, but you shouldn't have a 0 in Tier 2 or Tier 3. Please ensure that your summary numbers are correct each month. Errors in your summary data impact your facility's SIR. And as discussed at the end of each quarter, make sure you indicate primary CDI test method. That's at the bottom of your screen. If the test method is incomplete, it will cause the entire quarter's worth of data to show up as incomplete. I wanted to mention that there is a quality assurance report in NHSN that indicates when the CDI test method has been downgraded for your facility, which allows you to double-check the quarterly data entry for that CDI test method field. And so to check that, navigate to the line list called CDI test method history, which is the red arrow on your screen. Okay, so why is indicating the correct CDI test type so important? The CDI test type is used to risk adjust your CDI data, so the test method indicated directly impacts your facility's SIR. In this example, the number of patient days, the denominator, is the same from quarter 1 to quarter 2. However, you can see the number of events expected decrease from quarter 1 to quarter 2, and that is because the primary test method for CDI changed. When a less sensitive test method is used, fewer events are predicted to occur. The number expected directly impacts the SIR calculation, since you know the SIR is number of observed events over number of expected events. You can see that with the same number of months, events, and patient days, the SIR increases with a less sensitive test method in quarter 2. After you've completed entering all non-duplicate CDI events, NHSN will further categorize the events based on date of current admission and date of specimen collection. CDI events are categorized as community onset, healthcare onset, or community onset healthcare facility associated. Community onset healthcare facility associated events are simply a subset of the community onset events, and you're not penalized for either the community onset or the community onset healthcare facility lab ID events. However, with CDIF, hospitals are understandably focusing on the events they'll be penalized for, but we would like to emphasize that efforts should focus on prevention. And in thinking about prevention, you should be thinking about both your healthcare onset and your community onset healthcare facility associated events as targets for prevention activities. I wanted to make sure you all are aware of the lab ID indicator variables that are available in a couple different output options for lab ID reports. The indicator variable will equal 1 for all events that are counted in the numerator of your facility's SIR. We've had a lot of questions about which lab ID events count and which don't for CMS reporting, and these variables will give you the answer. There are several indicator variables available, but I want to point out 2 of them. One for CDI, which tells you which CDI events are being counted as incident healthcare onset events for your facility, and then one for MRSA bacteremia events, which tells you which MRSA bacteremia events are being counted as incident events for your facility. So the indicator variable will display as 1 if the event is counted in the SIR, and if the indicator variable is 0, then the event is not being counted in your SIR. To run a line list that includes indicator variables, navigate to the line list for all CDI lab ID events and click Modify. On this screen, as you know, you can set the time period of interest. Then scroll to the bottom to the Modify Variables to Display option and click the Modify list. A list of variables will be added by default to the Selected Variables list, including the key indicator variables for healthcare onset and community onset count. And you can see those on your screen. They're the 2 variables at the bottom of the list on the right. Any variables on the right will show up in the report that you run. From there, you can close this box and then hit Run. You can also export the data, but I recommend running it first in HTML mode so that you can see all the footnotes that the report spits out. Those are really important to read because they include notes about what data was included in or excluded from your report. Here is a sample line list from the report we just ran. The 2 indicator variables appear in the columns on the far right. You can see that event 40022, which is the first event, had a positive specimen on day 2 and is being counted as community onset. The event will be included in the numerator count for the backlight-in CO admission prevalence rate, as indicated by the 1 with a green circle around it. The second event, event 40023, is classified as a recurrent event. If you ran a line list without the indicator variables, you would see in the line list that the onset is classified as HO, or healthcare onset. However, if you look at the indicator variable, which indicates what is being included in the SIR, you can see that the recurrent event is not being counted as indicated by the 0 with the red circle around it. So, to recap, only inpatient, hospital onset, CDI, incident, lab ID events are counted in the SIR. The same logic applies to MRSA bacteremia lab ID events. If a patient has a duplicate CDI lab ID event within 14 days of a previous CDI lab ID event, the second or duplicate event will not be counted in the SIR. As discussed, this is true even if the patient moves location. Both events must be entered, but NHSN will not count the duplicate event from the second location in your hospital's SIR. And again, the same logic applies to MRSA bacteremia RABI events. So for both CDI and MRSA bacteremia SIRs, the number predicted is calculated at the facility quarter level using negative binomial regression models. SIRs are calculated on a quarterly level because of high variability and prevalence rates from month to month. Note that this means TAP reports should only be run on a quarterly basis or greater, which is annually, to generate SIRs. If your administration wants monthly data, there are other calculations that can complement SIRs for RABI data. For example, you can use prevalence rates to provide data on a more frequent basis. As with other rates in NHSN, these rates can be run by month, quarter, half year, or other cumulative time periods. You can also look at RABI trends by patient care area, or compare SIRs or rates to a previous time period within your hospital. This could be particularly useful if any targeted prevention efforts were implemented. So here are some resources for RABI, and the first link is for a 2-page info sheet, and problem number 1 describes the RABI indicator variables as discussed. Another helpful NHSN tool is the statistics calculator, which allows you to conduct statistical tests to determine whether there is a statistically significant difference between two measures. For example, if you're trying to compare two SIRs. The calculator can be accessed from the left navigation bar by selecting Analysis and then the calculator. This slide lists some additional resources, including a series of NHSN case studies in AGIC. Over the years, NHSN has been adding to this series, and they've been good trainings for hospital IPs or entire infection control departments. If you have an APIC membership, then you have AGIC access, but CDC is also looking at other places to publish the case studies to increase availability. And I put a link on here for the VHQC newsletter, and that's sent out monthly to all IPs across Virginia. If your contact information changes or if additional people join your team, please be sure to update your information with us. A reminder that May 15th is the CMS deadline for 2015 quarter 4 data, so that's coming up. And at this time, we will take questions.
Thank you. We will now begin the question and answer session. If you have a question, please press star and then 1 on your touch-tone phone. If you wish to be removed from the question queue, please press the pound sign or hash key. And if you are using a speakerphone, you may need to pick up the handset first before pressing the numbers.
Hi, this is Deb. I just want to thank our speakers today. I thought that they both did an awesome job, so thank you very much, Sarah and Karen. And this is our time now to ask questions, so you can get in the queue, or you can type a question into the chat box so that we can check them out and answer those questions. So, Hilda, do we have any questions in queue?
At this moment, I'm not seeing anything over the phone.
So, do you know if we have the results of the polling question?
Oh, good idea. Thank you, Sarah. There we go. So, Sarah, did you want to go over that?
Well, it looks like the majority of responders are saying that yes, they do, that they are doing surveillance for VAE, so that's good to know. That's not data that we're getting at the health department, but we know a lot of hospitals put work into doing surveillance for VAEs. So that's a good reminder for us that offering education for VAE surveillance is important since it looks like most people are doing it.
Well, and at the end of this presentation, you'll have a chance to actually put down what you want for future topics. So make sure that you do answer, the survey at the end of the presentation. So any questions yet, Hilda?
I'm not seeing anything. Just as a reminder, you can press *1 to get into the quiz. Thank you. We do have a question. It's from Diane Hollenbeck. Please go ahead.
Yes, I'm from Suburban Hospital. I have a question about MRSA bacteremia. We had a patient that came in through the ED, had a positive MRSA, then they went to the ICU. 2 days later, blood culture positive MRSA. Then they went to another floor, and 2 days later, again had a positive MRSA, but it came up as an HO on the lab ID events. Now, I saw it has a 0 at the end of the column, but are we being dinged for that? I'm not quite sure why it comes up as an HO. It was done within 14 days, although it was done on a different floor.
Yeah, if the indicator variable has a 0, then it's not being counted at all in your SIR. It's not being sent to CMS as a healthcare on-site event.
Okay.
So
it comes up as a hospital onset if it was within the 14 days. Is it just because they went to a different floor?
Yeah, it could be if it's being entered a couple different times. Then I think for each event, I think it's just looking at data collection for that specimen versus date of admission. So I think the algorithm is just saying, it's been enough days that it's healthcare on-site, but...
So it's past the 3 days, but...
Right, but then, like, the system as a whole is going back and saying, well, they've already had another specimen, and so this is a duplicate event, and it's not. The system doesn't count. Even though duplicate events get entered, the system doesn't count duplicate events against you. It doesn't count them in the SIR.
So even though it says HO, it's not counted against us as an HO.
Yeah, that's why I would recommend looking at those indicator variables, because that's going to tell you exactly what's being counted in the SIR.
So if it's a 1, it would be counted against us, but if it's a 0, it's not.
That's correct.
Okay, great. Thank you so much.
Yeah, we know it's confusing, and it's confusing about which duplicate events you should enter and which you shouldn't. We actually talked to NHSN when we were in Atlanta about maybe it would be a good idea if NHSN just accepts all lab ID events, like if you didn't have to track duplicates on a line list for your facility, if you could just enter every single lab ID event, and then the NHSN algorithm could kind of take care of the duplicates. Whether or not that'll happen, I don't know.
Yeah, it's interesting because some of them come up and it says duplicate and it won't enter it, but then some of them they do.
Yeah, that's what we're hearing is that IPs are just trying to enter all of them and then you instead of tracking a line list, IPs are entering all of them, even duplicates for the same patient, same location, and just seeing which ones NHSN will save. But I would encourage you to look at the supplemental slide, which is slide 93, and that kind of has some examples. Sometimes NHSN might accept this duplicate event, and then essentially you could be overcounting events in your hospital. It gets really confusing, and I definitely agree that it's confusing, and I kind of hope that NHSN will address it on a system-wide level.
Great. Well, thank you.
Yeah.
Once again, for any questions, please press *1.
So if you look at the slide that's on your screen, which is slide 93, these are duplicate specimens for the same patient all the way down. And so you're obviously putting in the first specimen. And so that was a specimen collected in the ICU. And then 6 days later, there's another specimen collected in the ICU. But that's obviously duplicate because it's within 14 days. And so the NHSN rule, as it stands right now, is that you're not supposed to put that in. And I think what IPs are doing is they're trying to put all specimens in, and so for that one, NHSN wouldn't accept it. And so you would be okay to just try to put all of them in because it's not going to accept it and knows it's within 14 days of the specimen on January 3rd. But then if you get to the third specimen, which is still the same location, and it was on January 20th, and you try to put that one in, NHSN is going to accept it because the last records that NHSN has is that they had a specimen collected on January 3rd. So if you have another positive on January 20th, that's more than 14 days, so NHSN will accept it. But it's actually still a duplicate because it's within 14 days of that second event. But NHSN never saved that second event, so NHSN isn't smart enough to know that you had an event on January 9th. And so that's where it's really important that internally you're keeping a line with, especially if you have one patient with a lot of different events or a lot of different positive specimens. It's really important that you're keeping a line with internally because you're smarter than NHSN. And then if you have the fourth one on the line list is February 1st, and again, that's a duplicate because it's within 14 days of the positive on January 20th. But again, it just depends which ones you put in NHSN and which ones NHSN has saved as to whether or not NHSN is going to know that's another duplicate. Does that make sense? I mean, that's kind of what I'm getting at, and I think it would be easier if NHSN just accepted all events and kept a record of the duplicates, but that's not how it's currently set up. If you get down to February 25th and they've moved down to a medical surgical ward, that's not considered a duplicate on NHSN's part because they've moved locations, and so you are supposed to put that in because it's the first positive for the location. But since it is within 14 days of a previous, if you look at that indicator variable for that event, for example, the indicator variable will be 0 because it's still another duplicate, so it wouldn't count in the SIR.
So, Hilda, do we have any other questions?
Thank you. At this moment, we have no questions over the phone.
Deb, there's no questions in the chat box either.
All right, well, I will turn the call over to Carol to wrap it up then.
Okay, so if we'll go back up after the question slide, we'll see that there are contact information for VDH. So if any of you have any questions about any of your NHSN reporting, we have a great list here of folks that you guys can contact and talk to. And on the next slide, we see APIC contact information with Karen, who presented today and had a great presentation. Thank you so much. And then as we wrap up the call, you see Deb and I's contact information. Should you need to contact us, we're available to you, and we'll be happy to direct you and assist you in any way we can. So I think we're at the very end of our presentation. We have a few minutes left, and since there are no questions in the chat box, or online, we want to remind you about the VDH online community. If you have not joined, please do that. And once you do join, click on the infection prevention area and go ahead and join that area too, so that you'll be able to have access to all the resources and networking that goes on the online community. So do we have any last words from any of our presenters? Deb?
Sarah and Karen again, thank you very much for today's presentation.
Right. And so from all of us at VHQC, the HHA, and Virginia APIC, we want to say thank you and so long for now.
Thank you. Ladies and gentlemen, this concludes today's conference. We thank you for your participation. You may now disconnect. Okay, Coach, I connected you back into a post-conference. I wasn't sure if you